Welcome everyone to today's webinar. I am Emma Goodman with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. We are thrilled to have Scott Becker, publisher of Becker's Healthcare, here to host the Q&A. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled "Enter a question for staff" and clicking send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenter. Brian Kennedy is a director of nursing at AnMed Health, where he implements technological innovations in workforce optimization and capacity management to improve efficiency and staff engagement. Brian has 20 years of healthcare experience in emergency services and critical care. Brian has a master's degree in nursing administration and a Bachelor of Science in nursing from Clemson University, as well as a BA in psychology from Erskine College. He is a board certified as a nurse executive advanced by the American Nurses Credentialing Center and a clinical instructor in the Graduate Nursing Administration program at Clemson University. Brian, it's now my pleasure to turn the floor over to you to begin today's webinar.
Great. Thank you, Emma. Thank you, everybody, for joining us today. We will start with just an overview of AnMed Health. So, Emma, if you can move to the next slide. We are a 5-hospital system in the western part of South Carolina, known as the Upstate. The medical center is our anchor facility, and we have over 100,000 ED visits annually. The ED accounts for about 66% of our admission volume, and so that volume creates a lot of uncertainty from day to day on what we're going to be receiving through the ED. But we've learned through these data-driven processes that just because it's variable does not mean that it's unpredictable. Okay, Emma, we can move along. As we move towards a model based more on value, we all have increasing pressures like driving volume to our lower cost settings, and that makes forecasting critical to our success. If we have inaccurate forecasting, that means that our physical and human resources are poorly aligned. That drives up labor costs, slows down flow, the ED gets backed up, and then patients end up boarding for hours. And in some facilities, we can actually lose volume to our competitors because of a diversion type situation. When we do open up beds for our ED patients to be admitted, it might be an off-service bed. Studies show that this can cause increased mortality and decrease the patient safety. When we have inefficient alignment, like a critical care patient waiting for a bed while on a med-surg unit, that can artificially increase the length of stay and result in reimbursement that doesn't quite line up with the amount of care that we're delivering. On top of all that, hospitals are facing pressures in staffing and scheduling. Most of us face a nursing shortage, and the Bureau of Labor Statistics says we can expect 1.2 million vacancies to emerge for registered nurses between 2014 and 2022. Hospital executives worry that they'll be able to have the right staff for their patients, and they wonder how they'll keep their staff happy and engaged. Next slide, please. to deal with these kinds of pressures, AnMed Health implemented an integrated capacity management model. Most of us have always used historical data to predict future volumes, such as in an accounting type situation. However, we can combine that data with predictive analytics to significantly increase the accuracy of our volume forecasts. We can use data to understand patient flow patterns and throughput and staff accordingly. Ultimately, we can remove the mystery around the data and put it into the hands of the frontline clinicians. And what that does is forms a bridge between executives' strategic goals and staff knowledge of the changes that happen every day that impact those goals. By being aware of the metrics, we can effectively improve patient satisfaction, staff engagement, and positively influence quality and staffing costs. Next slide. We have typically managed staffing and bed volumes based on the information we know. But doing that, we've had to rely on the hope that history will always repeat itself, and we've become accustomed to using averages in trying to match resources to demand. At AnMed Health, we partnered with McKesson Capacity Management to change our assumptions. We learned that not only are trends predictable, but deviation from trends often means that something affected our operations, not that we had an error in the forecast. As we started to embrace the concept, we realized that putting data in the hands of all staff was key to success. The transparency put all of our clinicians on the same page with one another and with leadership. Next slide. So today, I want to show you how we've used both historical and predictive data together to drive quality improvement at our facility. I'm excited about what we've accomplished, and I also want to share the challenges that we faced and that each of you might face if you adopt these types of metrics in your organization. And next slide, please. At AnMed, we were facing a lot of challenges that I'm sure you're all familiar with. We were looking for solutions to issues related to our highly variable census, like high labor costs due to agency usage and overtime. And we're always looking at length of stay to see how we can become more efficient in serving our patients. So we'll move to the next slide and have our first polling question. We want to know how many of you have used predictive analytics or historical averages to forecast your patient demand. We'd like to know if you've used one or the other, both of those, or if you're not really sure. Okay, just like us, predictive analytics is something new. We, like you, have used historical average. I'm excited to see that a lot of you are combining the two together. I don't know that any of us will ever want to move away from history data. And then the people out there who don't know how you forecast your patient demand, don't worry, because that is exactly what we encountered. And to be able to roll that knowledge out to your entire workforce is huge to get staff engagement and to improve the quality of the assumptions you're making. Okay, we can move on. We all know that variability comes from many sources. You can have seasonal populations such as snowbirds in Florida or the ski season in Colorado. Here in South Carolina, we experience seasonality as well. We have a 4-color system to indicate the criticality of our capacity at the moment. This graph shows a historical picture from 2012 and 2013 as we were beginning to use forecasting. You see that in the winter months we operated typically in the orange, which was a crisis mode, an average of about 27 to 28 days per month that we were near critical capacity and had minimal bed availability. However, you see during the other months we spent much of the month in the green. That meant we were downsizing staff and we're just generally operating inefficiently. I also want to point out in July of 2012, you see a small red bar at the top. That indicates a very critical bed shortage, and it falls in a month that we don't typically think that critical bed shortages are going to occur. We tend to think July, summer month, not a bad census situation. Without accurate forecasts, times like that become emergencies. With the new processes we've put in place, that's a situation we prepare for and can possibly avoid days or weeks in advance. If not managed well, all this variability will impact staff satisfaction and financial performance of the organization. This graph just represents our reality, and it shows why we can't continue to manage to the averages, or we would always be over or understaffed and missing our budget targets. So now we'll have another polling question. Yes or no, my organization's average length of stay is higher than we'd like it to be. For the people out there who said no, congratulations, because that's a huge hurdle that you've gotten over. The large majority of us, yes, we continue to see those high lengths of stay, and a few of you, again, don't know. And again, I say that's not a problem. That is an issue that we all face, multiple sources of data, multiple ways to display it. And so length of stay continues to be either a challenge or a mystery. And we have that in our staff's hands now. So they know day by day how their performance is on length of stay and several other throughput metrics. All right, so we'll move along. Both executives and frontline staff have access to data to help explain the variances that we see. This graph shows on the red line the average admissions, and on the yellow line the average discharges by day of the week. The blue bars show our average census across those days. I want to point out that it does start on Monday and ends on Sunday. We all have these gut feelings about when our high movement days are. But this chart shows without a doubt that we have high discharges on Monday and Friday, low admissions and discharge activity on the weekends, but through the week, we have a fairly stable census. But when we move to the next slide, we can drill down to a single unit. So let's go on. Good. On this renal unit, discharges peak on Friday. And so the census drops down on Saturday. And then on Saturday, the yellow discharge line drops out again. And what results is Sunday being one of the highest census days for this particular unit. This is an example of the frustration that comes with trying to obey the law of averages. Staffing this renal unit will need a completely different strategy than the rest of the facility. You would want to increase staff on Sunday for the higher volumes. And then you would want to increase resources like case managers or transport staff, those key members that influence the efficiency of the discharge process on Friday. Now we can move to the next slide. And here again, you have an organizational view. This graph shows our forecast with the gray bars, and then our actual performance with the light blue line. This long-term view through the end of December shows a level census. This kind of information is going to be helpful in deciding staff replacement or whether to bring in contract staff. What we have done is classically tried to replace staff during the summer, but what results is new hires are orienting during a winter surge. This kind of situation puts stress on preceptors and on their orientees. It leaves that new hire with a feeling that this work environment is chaotic and rushed and can leave them feeling like they're not prepared for their job. Knowing long-term forecasts can help us determine the urgency of hiring staff, or they can make us comfortable making a decision on whether or not to bring in agency. We become proactive instead of reactive. This forecast shows that a winter surge probably won't occur until after the end of the year. So we could be comfortable holding off hiring agency staff or allowing a hiring manager some wiggle room if they haven't found that right candidate by the end of the summer. Next slide, please. This is a different view of a similar graph. Again, the gray bars show the forecast, but the dotted EKG-looking line across the graph shows our staffing. And this is fed from our staffing system. So looking at this slide tells me that telemetry is running a very high census, but low staffing. I do want to mention that we have a resource team initiative to backfill some of that, so it's not as terrible as it looks, but the staffing is still low. Now, if we move from this telemetry view to the next slide, which is a medical surgical view, you can see that Med-Surg is running a much lower census and has adequate staff to take care of more patients than they have. In this kind of situation with this kind of knowledge, we can focus on staff competency, seeing if we have telemetry trained nurses working on the med-surg units, and get those people to the right locations rather than scrambling to call in additional resources that in the big picture really aren't needed. So now we'll have one more polling question. Yes or no, my staffing budget is deployed in the most efficient manner possible based on demand and patient acuity. Thank you all for your honesty, because this is a huge thing to try to achieve. I doubt we will ever be 100% accurate, but we owe it to our patients and to our staff to make sure we have the right people in the right numbers at the right place at the right time. And for those of you who don't know, again, you know, this is a complex situation. And oftentimes we will have highly qualified staff working in a lower level of care when a few changes could match skills to acuity in a much better way. And by looking at that general overview and being able to efficiently drill down, we can make those decisions with a lot more certainty than if we just make a phone call or send a group email. Okay, we'll move on. Depending on a person's level in our organization, there are different views that can help them. This type of view lets me check the pulse of the entire hospital. This shows admissions on the left and discharges on the right, with the prediction and the actual performance on a given day. Looking at this kind of graph was initially viewed as a way to challenge the accuracy of the forecast. However, as we went along, we learned that these discrepancies typically point to something else. In this case, you're looking at a med-surg view, and you see the admission red line exceeding targets, while the discharges were pretty much spot on. Now, I want to add in here that in addition to looking at daily and weekly forecasts, we are actually forecasting. We are actually looking at hour-to-hour forecasts, and you can see that we're having pretty good results with that. This is a common trend, this performing over the forecast that we've seen since we implemented a physician-driven model to decrease our tele usage. Since we implemented that plan, we've consistently seen this med-surg graph exceed the forecasts on the admission side, while we've seen the tele forecasts come under. So again, instead of looking at it saying something's wrong with our data, we look at it in aggregate and realize, no, our strategic initiative is working. For another example here, a few months ago, we saw a sharp decrease in patients moving out of the tele units on a weekend. We talked to the staff and to the cardiologists, and we realized that that particular weekend, there were several cath lab emergencies, and it impacted the physician's ability to make it up to the units to do the discharges. Now, when you're looking into something like this, there's no stronger message than an executive going to a frontline clinician and saying, we both see this data, but I need you to help me interpret it. There's also a huge return in approaching a physician before they approach you, saying, I see you're struggling and I want to do everything I can to help you. By having this data in front of you, it takes a lot of that emotion out of the conversation, and it eliminates that defensiveness. And instead, you can work towards collaboration. Next slide, please. As I've mentioned, a huge factor in our success with data-driven processes is our ability to put data in everybody's hands. This type of geospatial unit view appears on screens throughout the organization, on nurses' stations, computers, on monitors in the hallways, and on any executive desktop computer. Last year, we implemented a process for discharge planners to electronically highlight potential discharges in yellow, such as you see in room 552 or 535. These flags were placed at least 24 hours in advance, and as soon as they clicked it, it could be seen by staff, physicians, and leadership across the facility. This kind of transparency enhances the communication between clinicians and helps the leaders to watch the efficiency and the accuracy of the predictions. It helps us to put the resources in the right place to make sure we're achieving the target forecast, and it puts an end to a lot of that silo mentality by literally putting everybody on the same page. So if you'll move to the next slide. As a result of the improved communication and our improved teamwork, we cut a half day off our average length of stay. This reduction came from hours and not days that were shaved off the hospitalization. By giving the physicians what they needed in order to prioritize their discharge rounds, or helping nursing staff prepare the patient for discharge a day in advance, and planning with the families the night before discharge, we were able to reduce the obstacles that we run into on the day of discharge. This half day might represent a morning discharge as opposed to an evening discharge. The communication with the physicians improved because every member of the care team knew the priorities and some of the goals for the patient. By having staff where and when they're needed and information flowing throughout the team, we improved those partnerships with the medical staff. Relying on data instead of a hunch is a much more effective way of putting staff where we need them. And avoiding wasted productivity by bringing in people too early or keeping them too late, we were able to focus our resources. Physicians understand data, and they are typically naturally competitive. Being able to provide timely data helped us engage a lot of the physician leaders in reducing length of stay and a lot of our other throughput initiatives. And staff engagement is absolutely vital to our success. We're incorporating millennials into the workforce, and we see increasing challenges as we have more and more generations to try to accommodate. By relying on our teams to complete the leader's vision of the organization, we recognize their worth and we acknowledge their expertise as being vital to achieving our strategic goals. Okay, if you'll move along, we will talk about some of the barriers we ran into. These barriers will be familiar to a lot of you for anything you've attempted to implement. Ultimately, this kind of initiative has to come from the top. Leaders have to believe in the data before they can even hope to gain the trust of the staff. We're so conditioned to using historical data that it's a challenge to shift gears and conceptualize future data being reliable. On top of that, leaders are familiar with using data to plan strategies and to assess outcomes. Frontline staff may not have that comfort level. We've got to support the staff as they operationalize the data they see and help them find opportunities and celebrate wins based on that data. We have a lot of long-held gut feelings that may or may not be true. Staffing to demand based on the numbers may not be consistent with what staff have always thought they knew. Low staff on the weekend and high staff through the week is a common practice. Having the most staff on the unit for the morning shift is another norm that we struggle with. Our data showed that in certain units, higher staffing needs to happen on Sunday or from 11 a.m. to 7 p.m. instead of 7 to 3. Everybody on all levels must get comfortable with using the data, but once they do, they can understand the reasons behind the decisions we make. And ultimately, everybody has to be able to see and to understand the data. Different dashboards provide different views in our organization. Some of these dashboards are streamlined for the concise information that a clinician needs to quickly see. Other dashboards have robust data and complex charts that will be familiar and useful to executives. Now, if you'll move to the next slide, please. To wrap up, using an integrated approach to capacity management by bringing together forecasts for planning, staffing, and transparency across the organization, these have allowed us to build data-driven plans and schedules to align our resources with demand. These processes bring all the pieces together to drive the timely provision of care for the patient in a cost-efficient manner for our system. So we can move to the final slide, and now I'm going to turn the webinar over to Scott Becker, who will moderate our question and answer session.
Brian, thank you so much, and that was very informative and helpful. We've got a number of questions from the audience. Let me start with a couple. In terms of predictions, using sort of data analytics to predict capacity and to use that as a management tool, how accurate has this been as a tool? How useful are the predictions?
Scott, when we started the process, that was probably the number one question on our mind. And we tracked the data down to the level that we could determine accuracy 1 day, 2 days, 7 days out, because we wanted to know, are we missing anything? Is this all smoke and mirrors? We found consistently a 98% or greater accuracy all the way to 7 to 14 days out.
So essentially, significantly improved, obviously never perfect, but significantly better.
Definitely. And go ahead, Scott.
Well, let me ask you a question. There's a great question here. Did you face challenges with staff agreeing with and trusting the data? How long did it take staff to get educated on it and sort of to start to see the usefulness in the data?
that was a difficult hill to climb, and I will not sugarcoat it, bare minimum 6 months, because the phenomenon that we saw was a transition from managers saying, we are predicted to have 7 discharges today, but I only see 3, so I think it's wrong. But by the end of that 6 months, we had managers coming in saying, we're predicted to have 9 discharges, and I've only been able to identify 5, so I'm going to call our case manager to help us figure out where the other 4 are. And that's the point when you know you've turned the curve.
They've started bought into the concept that this is very helpful and that they have to staff for it and use it as a real tool for staffing.
Exactly.
And one question that relates to something you had just said about 7 and 14 days. How far into the future are you able to use the prediction capacities or analytics? What's your time frame? I mean, some of this is seasonal, but sort of in your regularly looking at what you're working with, are you looking at 7 to 14-day cycles, 2-day cycles? What are you looking at in terms of into the future predictions?
Well, as I showed during the presentation, we can look about 6 months out. You saw a quarterly view, but we can do a half-year view. We are preparing to forecast our 2017 volume at the end of November. So you can certainly look for big trends on an annual level, and then we tend operationally to look 2 to 4 weeks out. We basically want to be correlating this to staff schedules and to similar plans like that.
Got it. Let me ask you, we've got another question about 2 questions that relate to data sources. The longer the questions is, using various sources of data from different department systems, what sources of data are using different department systems to collate and sort of put into the system?
Our data comes from 2 sources. We have a feed from our admission discharge transfer system, and then we have a feed from our staffing system. So that's ultimately the demand and the resource being addressed by those 2 sources.
Gotcha. Would you just repeat that again so the audience has that? And is it coming from all different areas of the hospital or really principally from those 2 areas?
Well, it comes through our ADT system by an HL7 feed, so we get it for the entire hospital. We decide on the programming end which units we really want to track, and typically we've stayed to a few outpatient clinics and generally our inpatient areas. But we get the data for everything and can use it the way we want.
And how have you decided, you made a very good point there, that you focus the efforts around a few key areas. What are the few key areas that you've chosen as a system to focus on? Let me ask you that question.
I'm sorry, Scott?
Let me ask you that question, Brian. It's the question of, you had made a point in your last point about how, it's really a few areas, inpatient and a few outpatient clinics, that you really focused the most of your work around. How did you choose that, and where do you focus most of your efforts? Did I hit that right?
Okay, I see. Well, I mean, generally, we're not focusing on a particular unit. The way our system is set up, we look at units in aggregate as a telemetry group or a med-surg group or a critical care group. We've tended within those groups to focus from a data perspective on how well are we matching staffing to projected capacity, and how well are we performing as far as discharges and admissions, but particularly on the discharges, because that's the area that our staff, both medical staff and nursing staff, tend to impact the most. If those discharges aren't happening, then we need to be digging in and finding out why.
Gotcha. And how the improvement, you've said something very interesting about the improvement of capacity management. So many systems over time had used sort of really anecdotal or sort of, what people thought was going to happen versus a more disciplined system. How financially beneficial has it been? If the biggest benefit's been financial to moving towards this, has it been morale? How big of financial benefits have there been from having a more systematic, disciplined way of looking at this versus the anecdotal that you used to have? How much more efficient is it? Just a few thoughts and comments on that.
I would say that the financial gains are certainly there. They're mostly secondary to other accomplishments. By keeping these patients out of the ED, we can affect patient satisfaction scores. By getting a critical patient moved from a lower level of care because we had the capacity, because we anticipated the need, that's going to help the nursing staff, that's going to improve patient safety. So it's really a very holistic type view that you just have to take all of your wins and put them together. It's certainly, there's a huge potential to make life easier on clinicians all across the healthcare continuum.
You got it. To be successful in implementing this type of system, the first question is what types of resources do you need internally or externally to sort of get this going and then commit to being successful? That would be the first question.
It takes a very unique resource to maintain this system. Of course, putting any kind of major system in place is going to take a lot of work on the part of IS and infrastructure and things like that. But to maintain this system, you pretty much need somebody who's well-versed in both informatics and in the clinical arena, particularly in the leadership area of understanding flow and throughput. So, it's a relatively hands-off system that we use once we get it up and running. We just need a person who can put that data together and get it out to the staff in a way that every level can understand. You also have to have a cheerleader, somebody who can go out and really onboard people to build enthusiasm for the system. But from a purely technical perspective, once it's up and running, it's fairly easy to maintain.
Well, let me ask you a question related to implementation. What was the process that led you to decide to try the system, and then the timing from and sort of core implementation steps from deciding to try this as a system to implementing it to actually starting to get it used?
We had, conservatively, I want to say 1 year, but I would probably say closer to 18 months. And we were fortunate to have a progressive executive team that really advocated to try this out. We were one of the first U.S. hospitals to use this type of system, and there was a lot lost in translation. I mean, this particular system was born and bred in New Zealand, where nationalized health system and a lot of different priorities. So included in that 18 months was a lot of just learning how we needed the system to work in the U.S. market.
Gotcha. So about 18 months from really embracing the idea to really getting useful. Could you imagine a situation going back to anecdotal, paper and pen, just ideaizing on staffing capacity today?
I would probably relate that to asking a physician, can you imagine diagnosing a patient before x-rays were invented? It would be extremely difficult.
And there'd be a ton of cost and problems in going backwards, is my sense of what I'm hearing.
Definitely. I mean, we've learned things, and we've learned just to reach our computers to get information to make decisions that if that was taken away, it would probably feel a little uncomfortable.
Thank you. Next question, the census numbers. I've got a question here on whether they include inpatient numbers only, or I think the question is outpatient patients as well, or it might be obstetric patients as well. Either way, can you answer both questions? Do your census numbers and how you look at this include inpatient numbers only, or do they include OB-GYN, or do they include outpatient too?
We currently don't have a lot of resources dedicated to outpatient. Now, OB-GYN, yes, we have, both for our outpatient labor and delivery and for our inpatient services. And I also want to add in, we monitor the emergency department with very similar graphs that you saw today. And even I still have trouble wrapping my brain around how predictions in an emergency department could be accurate. But the algorithms we are using, they are almost as spot on as what I showed you in the presentation for the inpatient side.
Gotcha. And you would expect that, even though you might not be able to expect the exact types of emergencies, there are different peaks and valleys of timings in emergency departments, and this just gives you a much more systematic way of looking at those, I take it.
Well, it does, and this is where the manual input comes in. For instance, hope it doesn't happen again, but a few weeks ago, South Carolina had to evacuate some of our coastal hospitals. Well, that's going to take somebody going in and making an adjustment based on what we know is going to happen, and obviously that's something that's not going to be predictable. But our system has a provision to actually go in and flag that day so that the system understands this occurred and it was a deviation, and it's a natural disaster flag that we could put in the event of another event that would help the system to learn and accommodate that.
Gotcha. And you've got a predictive analytics solution to capacity management. There was a question of whether you have an acuity solution as well.
We do not, and the geospatial unit view that I showed you, it does have an acuity flagging system in it, but on a system level, we have not yet adopted an acuity system, so we don't use that right now.
Got it. We've got a number of great questions. So we've got the acuity solution question. The next question is, what kind of approach do you use to make predictions? Is there a specific method using averages versus not averages? And what do you do to make such predictions accurate over 7 or 14 days?
Unfortunately, I can't speak in depth to that, because if I could, I would be retired on an island somewhere. But the system we use, this system has 25 to 30 algorithms. And when we set up, the system actually calculates a percentage of error. And it bases on a weekend average or a weekday average or an hourly average. And then there's even other things it pulls in to certain algorithms. So when we set it up, we choose the number of algorithms, and you could choose all 30. That will give us the best prediction. And during implementation, we were taught, because it gives you kind of a margin of error, and you have to find a common ground that you're comfortable with, and then it uses all of those algorithms on top of each other to increase the accuracy of predictions.
And a question on the use of the predictions. Are your managers using the predictive analytics as a tool to build out their schedules, regularly? How do they use this in terms of scheduling and staffing?
Well, typically, Scott, we have two approaches. The first approach is they're making the next month's schedule. They will take into account that information. And so if they have an RN on leave of absence, they will make the decision then. Do I need to look for somebody to replace that resource, or can I live without it for the month? So that's kind of the long term. And then on a daily level, we look at the next day's projections, the next few days' projections, and we decide, I have 5 nurses and this unit has 3, they're going to need one of my nurses, or they're not going to have any patients and I'm going to need one of their nurses. So we're trying to get ahead of it and try to make those adjustments at the time we need them on that level. So 2 different views.
And has this been more successful in some units than in other units? The implementation of the capacity management system. Can you speak to that?
Yes, it is, and it's not because of any kind of data accuracy. It is more to do with the culture of the unit. And that's why I emphasize that you really need somebody that can get out there and build the momentum, because certain groups of staff, certain managers, depending on so many human factors, are going to be more or less likely to embrace something like this. I mean, it takes a leap of faith.
So you're finding, and it goes to one of the great questions earlier about trust in the staff and the analytics, but it also requires somebody to be a champion in different departments. You're finding as a leader in this that the overall information and data is pretty good across a lot of units, and then a lot of it depends on the human embracing of this from unit to unit. Is that a fair statement?
Yes.
Okay.
Yes, it's the classic pattern of early adopters versus late versus laggards. I mean, it's almost a bell curve.
And then hopefully sooner or later, most of your departments get up to speed where they're using this pretty well, because it's got to have so many benefits in terms of systemizing these issues versus guessing on them. But
yes,
it's basically getting people on board that that's the better way to do it.
Definitely, and I remember the day that my particular brick wall in our organization said, wow, I really should have listened to the data.
Gotcha. And you don't want to name that person on the phone now. We'll avoid that. Just kidding. Brian, clinical ancillary departments. How involved are the ancillary departments, and how much are they part of this and what you're doing?
We have not been as successful as I would like at bringing them on board because, well, first of all, because it's a lot to wrap your brain around, but there is such a huge potential. The physical therapy departments, the materials management departments, supply chain, I mean, they're all impacted by this, so it would be huge if we could bring them into this as well.
Gotcha. I had one of the questioners had provided a correction to my question that I answered wrong. So on the census question, inpatient, are you counting inpatient patients as well as observation patients? And I had misread that he meant observation versus OB-GYN or outpatient, so I apologize. But how are you looking at observation patients as part of this?
Yes, we actually threw a curveball to the New Zealand team when we said these are distinct patients and we need to know both. So we have actually made a system to track our observation patients separately from our inpatients, and as a result of a lot of the work we've done, we have in the past year opened up a dedicated observation unit, and that data was instrumental in making that decision.
Let me ask you a follow-up question to the timing on this. You were an early adopter of this system as they sort of embraced it from originally a system used in New Zealand. We're early adopters. So if originally it was 12 to 18 months to get this on board and really going, would you guess that this is a much quicker amount of time today?
Yes, definitely, and only because the New Zealand program is not a good fit for the U.S. market, and thanks to a handful of hospitals really going in and working on this, we now have a system that is much better suited to the U.S. healthcare environment.
Gotcha. So the implementation time today, from sort of picking the system at McKesson to putting this to use, much quicker than it was when you first started on it as an initial sort of generator and user of this. Okay. The next question was, did you have to beef up case management staff as part of this, or was that not really an issue specific to this?
We did not, but that data has been useful for case management leadership in asking for resources.
Great. There was another question about whether you use teletracking and the full-time employees allocated to manage patient logistics.
We do. We have the electronic tracking system. The board that I showed during the presentation is actually our version of electronic tracking. We don't use any kind of RFID, so it's all a manual process of moving these patients through the facility or triggered by the computer systems. But yeah, the view that I showed you, if you go into our bed control board, you actually see about 20 computer screens in front of a person with all of those unit views on it that helps them to do the patient placement.
Gotcha. Another question. Who was responsible, well, who worked with physicians, or how did you work with physicians to prioritize discharge rounds? I mean, how...
We've had the...
Oh, go ahead.
We've had the most luck with our hospitalist group, our internal medicine doctors. You know, the surgeons have typically always embraced that concept of I need to get my patients out right away so I can get my new patients in. But on the medical end of things, there was typically an opinion of I need to start with my most critical patient. But what resulted was a critical patient with orders to downgrade, but the less sick patients still occupied the beds on those downgrade units. So it helped us to kind of turn it upside down and start from a different direction.
Gotcha. It really made you think differently about how you manage discharges with your physicians, in particular your hospitalists. Your surgeons, it sounds like, were always intent on moving people out. Your hospitalists spent a lot of time in the most critical patients first, and this at least allowed you to reallocate resources a little bit in how you approach that and be much more effective and efficient.
Exactly.
Gotcha. And that makes sense. Case collection of information. Who was responsible? What were some of the challenges in data collection, and at least initially, and then distribution of data? Maybe a couple thoughts on getting data and distribution.
Are we talking about from a case management standpoint?
I think in terms of implementing the system as a whole, how did you get started in getting the data into the system, and how much effort was there?
Once the feeds are set up, it was fairly easy, but I didn't do that, so I can say it was easy. I'm not sure how much work was involved, but I do know that once it's set up, this is a fairly continuous feed. I mean, this is an every 15-minute update, so it's data intensive. I just don't know what was involved in getting that running.
Let me ask a question. I know that ANMED and McKesson have worked very closely on this. There's a specific question about, is there a particular McKesson system that's being used as part of this, and is there a name of that system?
Oh, well, the system that we are using is McKesson Capacity Planner, and we're using that in conjunction with McKesson Performance Visibility.
Okay, so just for the audience, I know somebody asked a specific question. Could you just repeat that again, just so if anybody has questions, they at least have the tee off on the specific systems you're using? Brian, would you mind repeating that? I'm sorry.
Sure, no, not at all. It's McKesson's Capacity Planner and McKesson Performance Visibility.
Gotcha. Great. We've got one more question here. I know that we're and we'd encourage other questions as well. And we're happy to go past the hour. If people have more questions, we'd be delighted to, as long as, Brian, if you've got a couple minutes. I know I've got one here. On using predictive to schedule, does a prediction drive scheduling or just provide a separate template that has to be manually used to refer to in scheduling? And I think the question is, the predictive analytics will give your department, people that are putting schedules together, the information they need. But then, Brian, is anything automatically done, or do people still have to look at their schedules to decide, using the data, what they're going to do?
Well, and there's several different levels to that. McKesson actually has an integrated scheduling system, so I really am not so sure what they would say. For our system, we typically are decentralized as far as scheduling. I think that it would look very different if we used kind of a central scheduling system. I won't speak to the staff engagement piece of that, but if it was centralized scheduling, I'm sure it would drive allocation of resources across the system. Instead, we have to use, since we do it unit-based, we tend to have to collaborate among managers based on the information we're seeing, because they in essence own those resources and have to kind of move them between the units.
And that's kind of the work of the internal champion and manager of this, to make sure that people are actually using the data and using it well, and to reallocate people and move people and schedule appropriately. I mean, that's sort of the internal management part of this, I take it.
Yes, and we had a lot of luck with bed meetings, but whether in face-to-face bed meetings or even online type meetings with kind of a computer view of where the staffing was at across the organization, so that we could kind of visualize where the resources were versus where they needed to be.
Great, and thank you. I think we've now hit most all the questions that were asked. I want to take a moment to thank Brian Kennedy from AnMed Health. Just a wonderful discussion, and thoughtful and intelligent and helpful, and most all the attendees stayed on for the whole time of the presentation. So I take it they found it informative and useful. So, Brian, thank you very, very much. I also want to thank McKesson, who is the sponsor of today's webinar, for their support and their help. And again, thank McKesson very much. I know the two products that you discussed that you're using were the Capacity Planner and the Performance Visibility. Did I say that right, Brian?
Yes, you did.
Okay, so thank you so much. But just a terrific discussion. These discussions, where they're very thorough, helpful to the audience versus any kind of sales pitch, are so helpful, and we appreciate it greatly. Just a terrific job, Brian. Thank you so much. And thank you to McKesson. And I take it from the McKesson people and Brian, if people have follow-up questions or issues, that we'll be able to help get in touch with the people from either with Brian or McKesson. So thank you so much, Brian.
Great. Thank you,
Emma,
Scott. I really enjoyed it.